Hi! Welcome to Nurse Twin Talk.
I'm Karen.
I'm Julie.
We are both LPNs.
Which is licensed practical nurses.
I've been nursing for 12 years now.
And I've been a nurse for 15 years now.
Right now, I work in the hospital.
And I work in long-term care.
Today, we're going to be talking about the differences between long-term care and hospital setting.
Working as a nurse in those areas.
Yeah!
So the biggest difference, I guess, is the number of patients you have in long-term care. I have 26. You could go up to 40, but you have?
I have between 4 and 6 patients that I'm responsible for on my shift.
Another thing is, as a licensed practical nurse, a big part of it, you feel like a pill pusher.
Pill pusher.
I'm your drug, you know. I'm here to hook you up with your drugs because there's 26 people to give drugs to. So, you know, I work afternoon shift, 3 p.m. to 11. So that's separate and bedtime meds and a whole bunch of PRNs, which is give as needed. And they need it.
Yes, and you know, 26 patients to give medication to is a lot because they each have a lot of medications, and you have to know all these medications, all their side effects, why they're taking the medication. You got to give the medication on time.
We're not going to get into the 10 rights of nursing. I mean, you
no,
don't
we're
have
not
time
going to get
for
into that. You can Google
That's
that.
Not the real world.
But but it takes a long time. So in residential, literally your whole shift revolves around getting on medications.
But you know, you got to make room for other things, right? Like there's behaviors, there's falls, there's wound care, there's family members who are. Oh my gosh, we'll make a whole other video about that. No, just kidding. No, but they are.
We love family.
It's 26 plus. You know, let's double that. 52. You've got a resident and you've got their family member who apparently you take care of too.
Absolutely. Absolutely.
Absolutely.
Now, in the hospital, you have significantly less number, which again, you're taking care of medications and wounds and families, but they are more acute. These people are more sick and they have a current issue going on right now that you have to pay attention to, and the doctor is constantly writing orders. You have to look up, what do I have to do next? What's going on? And you're constantly doing your head-to-toe assessments on these patients as their health is constantly changing. Are they getting better? Are they getting worse? Is this a new issue I have to address the doctor about? What's going on?
Yeah, and long-term care, they are stable. They have chronic diseases. I mean, some of them have 10 diagnoses. A big thing is depression. Yeah, they're very depressed. A lot of it is dementia, which causes their behaviors to be erratic. They can be delirious from urinary tract infections.
Yes, and we see those acute medical issues when they come in. I mean, come on, delirium is huge. Huge. Yeah, and so we actually have a delirium protocol at the hospital that the doctor will sign off, and right away we have orders to collect specs and give meds, and that's great.
Whereas in long-term care, we can assume and suspect, oh, this person's acting different today. I bet you it's a UTI. Yeah, but we gotta call the doctor. Can I get a urine sample?
And what's the doctor say?
Well, actually, that's another. So I called the doctor once, which is, I won't mention his name.
No,
and I was very concerned
mention his name, but I know what doctor she's talking
about my patient. And I gave him all the information about her age, diagnoses, symptoms. And he said to me, oh, that's too bad. Yeah, it is too bad, doc. Now, can I get some orders for some antibiotics, or what do you want to do about this? Anyways,
that's a whole nother topic.
I'm sorry.
The relationship between nurses and doctors can be very frustrating because as nurses, we want to speak up, advocate for our patients, and we are powerless without a doctor giving a doctor's order.
Yeah.
So
there are some really super great doctors out there.
There sure are.
And then you'll come across the super beepity beeps
that maybe just don't see things the way you see them, where this patient really needs something. And they just don't want to do it for whatever reason.
Yeah, and then you're like, oh my gosh, I have to call that doctor about something.
So
hey,
the patient suffers. Really, the person suffering is the patient.
Yes.
And as nurses, you just feel deflated and you feel like, why am I doing this job if this doctor won't support me?
Yeah.
So it can be very
frustrating. Another thing about long-term care is they're not in their hospital beds, like in the hospital setting. They're pretty much in there. I know they get up to go to the bathroom and walk the halls too and sit up in their wheelchairs, but this is their home in long-term care, so they have free roam. And it is a least restraint policy. So they're frail, they're old, they're very weak with their walking, a lot of them. So they have a right to fall. And so you're going to deal with falls.
Yeah. And in a hospital, if we know that someone comes in and they are at fall risk, we're going to do everything possible. We're going to give them a bed with a bed alarm, which
Same long-term care.
you
Yeah.
do. We're
They're
going to
not always available
hopefully
right away.
try to get them close to the nurse's station so there's even more staff to be watching them. Oh, so-and-so is trying to get out of bed. Let's see what we can do for them. What do they need, first of all, and address whatever that need is.
And sorry to cut you off, but long-term
Cut me
care
off.
with 26 beds, sometimes the person who's a high fall risk is way down a hall, turn another corner and down that hall.
Yeah.
By the time the bed alarm goes off, guess what? They're already on the floor with a broken hip.
Broken hip.
Yeah.
Woo! Ouch. Okay.
Or split their head wide
Lacerations.
open and their blood. Okay.
Okay, there's a whole nother thing.
Or it's not always that
Head
dramatic.
injuries. So in the hospital, when that happens, if there's a suspected head injury, and it's got to be really bad for a doctor to do this, but then they're going to order CT scan, because if there's a bleed going on, we want to know about that, and then the patient's going to need different kind of care. So
you've got the luxury, you've got those equipment at the hospital.
Got the
Where in
luxury.
long-term care, we have to assume, well, we didn't see them fall, so did they hit their head? They have dementia, they're confused, they can't tell us. We have to assume they hit their head, so we do the neural vital signs, which will tell us, okay, they have quickly changed with their vital signs. They are acting differently. Within the first few hours, you can notice.
Vital. Okay, so a typical day. We're getting to work. Both of us, we do a lot of afternoon shifts, 3 to 11. And
You do graveyard too.
yeah, it's not fun. If you don't have to do it, don't do it.
You're like a zombie.
Does not feel good. So, but an afternoon shift is actually, can be a very busy shift. In the hospital, it can be very busy because that's the time of the day when most of the doctors write their orders. Right in the afternoon, right when I'm starting my shift.
Oh, they don't write them in the morning?
No, some do, but most of them is the afternoon, where I work anyways.
Okay.
It'd be great if they wrote them all in the morning. But no, so I'm coming on to chaos. I'm coming on. The other thing about working in the hospital is you don't always know who your patients are going to be. Residential, when you work in a place,
Right. That's
you
what I wanted
know
to say.
Mary Joan, Bob Smith,
Yeah.
everybody.
Yeah.
I don't know my people. I don't know who they are. I don't know why they're here. And so I got to learn all about that in shift report.
Mm-hmm. Which is kind of nice to long-term care, I guess, because you do see the same faces all the time. You bond with them. They become your friend. You become worried about them. And then some of them you're like, oh my gosh, I'm going to be with this person until they pass. And you're stuck with them. So
Yeah.
it's not always a good thing. Or you've made a bond and they pass away, which is
Yes.
what happens.
That is definitely
That's
true.
heartbreaking.
I would have to say that I do miss that about residential experience sometimes. But then-
Sometimes it is emotionally draining.
yeah. It is. It's hard coming on not knowing who your patients are going to be, but sometimes it's also kind of fun. Like, oh, what's happening?
Here today, gone tomorrow.
Yeah. Well,
Okay.
we hope the doctors, the health authority would like it to be a faster revolving door than that.
Oh, of
That's
course.
not always the case. These people have complicated, multi health issues, and so much homelessness. So much homelessness. So
Yeah.
yeah, we don't just kick them to the curb. We have to find somewhere for them to go. So that takes a long
Which
time.
they end up going into long-term care.
Long time. So sometimes I do know a lot of my patients because of that.
Because they have nowhere to go. They can't go back home. It's unsafe for them. No one to take care of them. Now their health has drastically changed. And a lot of my people do come from the hospital because they were admitted to the hospital with delirium and sudden health changes. And their health has changed so much they don't function like they used to. So they do need around-the-clock care now.
Around the clock.
Around the clock. 24.
Yeah.
Yeah, I'm walking into a long-term care facility 3 o'clock in the afternoon, so all chaos has ensued. So knowing my people, like, I care about high fall risks. Okay, I don't want to deal with a fall. What behaviors? Sundowning with dementia? Girl, that's when it happens. They're confused. Sundowning is they just...
What is sundowning, Julie?
Oh, Karen.
It's
It's basically they don't know, okay? The sun is up and then it comes down. They don't understand it's evening time. And
Yeah,
their body
so
clock
when the
is
sun is going down in the evening,
sundowning.
they think, whoa, it is time to wake up. It is morning.
They think the
My
opposite.
day is just starting. Their clock is just backwards.
So they're wound up. Think of a
Yeah.
little child who's overtired. They are just wound up. So I deal
Yeah.
with a lot of behaviors.
Yep. And in the hospital too. Definitely we see a lot of that.
But your guys' way of dealing with behaviors in the hospital is a lot different than long-term care. You do not have the time to sit down and talk someone through an emotion or give them... Don't laugh. There's a lot of counseling going on.
Oh no, I'm agreeing with you 100% at that.
Or try different techniques, or here, put them in front of the TV, or give them something to color. I mean, distract them, different redirectional things. In long-term care, it's like a home setting, so you're lucky if you have those type of things. And they do not have enough activities in the evening. That's the government for you. No funding.
Yeah.
It's all during the day shift. So the evening shift, we are their entertainment. Yeah, hi nurse and entertainer, counselor, pill pusher.
It's constantly
Detective,
overwhelming, and
constantly.
we feel very understaffed
Choking,
because
someone
these
choking.
patients need extra attention. They need one-to-ones, and we don't have them.
And
so,
like just giving like an animal something to pet, you know.
yeah, it'd be really great if these people would have more family member that can come in and sit with them.
But not all the
Be
family
with
members,
them.
because a lot of them are cuckoo crazy. So you can go home.
Yeah.
We got it from here.
But there's some definitely challenges.
Some that are really good though.
Challenging family members, and we understand. I mean, we have family ourselves, so we know it's hard. If we had a loved one in the hospital, it would be hard to be with them every day because we all live our own lives,
Absolutely,
busy lives, working
absolutely.
with our own families at home.
Yeah.
So we
But-
understand that too. Something else too, in the hospital, we have to assess our patients every shift, every day, with this stethoscope.
Can I be your
That's just part of it. That's just part of it. We have to do a complete head-to-toe assessment of everybody. And in residential, you don't have time to do that on 26 of your residents.
Time, no, not on 26, but
No.
there are people, you know, you check their vital signs
Sometimes.
monthly. You've
Yeah.
got glucose,
Because they're stable.
blood sugar. You got blood sugar
Oh,
checks.
so
and
you have to do that.
other
Yes.
vital signs you're checking. But yeah, I don't
Yeah.
walk around wearing my stethoscope.
Oh, lab work. That's something else.
Oh.
A big difference. Patients usually get daily blood work in the hospital.
Oh yeah, and then
And who has to look it up? The nurses have to look up the lab results, and they have to let the doctors know and be alerted about whatever's going on, so that they can pay attention to it and address that with medication or fluids or so forth.
yeah, and in long-term care they have the lab who comes by weekly, and it's usually the most pressing ones are the INRs if they're on blood thinners.
INRs, International Normalized Ratio.
Very good.
And
Because I forgot that.
talk about what does that? Who cares about INR?
We're not talking about that.
We're not talking about that.
Okay, we're
Okay,
talking about the
fine.
difference. Hospital, long-term care. So what do you like, Karen, about working in a hospital setting? What do you like?
Well, like as I said previously, I like working with people. So that makes me. I don't like to be working alone in residential. That's probably the biggest thing for me. Is I like to come on
working
and
with the
have
nurses.
coworkers to, a support team that you're working together, talking together. So I don't go mentally crazy, and it's just we're there to support each other, and it
Yeah.
makes the job more fun.
Yep.
I also do like having new patients often.
Yeah. What I like about it is, again, working with good people, if you get some good people. And my nurses who work on other floors, I mean, we get together, we have breaks together, we can always call them. But also the residents themselves, they, you bond with them, it's been a while, and like I've got the radio on in the evening, and we have some good times. They are hilarious.
Rocking it out.
Yes, because you just make fun. If you're having fun, they're having fun, and they can be so cute. With their confusion, lack of hearing, the conversations that I hear sometimes, the repetitive questions to another one, and it's like they are so cute and hilarious. That makes sometimes. Okay. Is that all I like?
Anything else you want
Watching them. And with long-term care, I feel like there's no snotty RNs like you get in the hospital.
Why we're
setting.
not talking about that? We said.
Well, I am, because I remember working in the hospital a little bit, and you've got RNs who are just
no!
okay. They look down on you.
with
like,
some really good RNs.
no, they're not all bad, but that's where you find the bad ones. You don't usually find
Okay.
them in long-term care. I mean,
That's
some,
right.
but-
If you were ever to find a difficult RN to work with, it would be in the hospital.
okay.
But I don't work with bad RNs. I work with some really
Yeah, okay.
I'm
Enough said.
very blessed.
Yeah. Okay. Now another thing, Karen. Do you have any unforgettable moments?
Oh, I should
I know
have been
there's so
prepared
many.
for that
You should have been
question.
prepared because I did some thinking about this one. Unforgettable.
Yes, obviously
What
it's
you
forgettable
are.
right now.
I know. Sorry. Okay, we'll cut until you really think about it. I'll give you some time to think that over. Oh, okay, we're back on. We're gonna talk about
Back
the
on.
differences between what happens when a person passes away in long-term care versus when a person passes away in a hospital setting.
They have passed.
Okay, so in the
Their
long-term
body
care setting,
remains in the bed.
it is
Now what?
Well, you're going to remove all of their tubings, make the body presentable.
For who?
For the families,
For the families.
which if they're not there and if they want to come later to view, but most of the time they are there. They want to be there.
Yep.
Some don't though.
Because we usually do have some kind of warning that their loved one
Sorry.
is going to be passing in the next few days or
Everyone likes
today.
to know, like, is it going to
So
be?
family
Do you know when
should
it's
have
going to
known
be?
ahead
I'm
of
not
time.
God. We're
Not
not God.
always.
We don't know. I mean, there's a lot of
Yeah.
signals you can guess, but
Yeah.
I never say, oh, it's going to happen tonight. Maybe
Okay,
you wanna spend the night.
so family
Okay,
is
so-
here and
so
they
fa-
want to spend some time with their loved one.
Yes.
Right after they've passed.
Yeah.
They want to sit with them and be with them and have a mourning time.
Yes.
That's very important. But how long can this body stay here?
Well, it starts to decay really fast and it starts
Immediately.
to smell immediately. So right now, you've got to get on the phone in long-term care and call that funeral home and they have to arrange to pick the body up, which
Okay, so long-term
it used
care.
to be long-term care used to be the nurses making that phone call. I think it was like a couple years ago they changed it. Now the families have to be the ones who are going through all this grief. They have to be the ones to call the funeral home.
Yes.
We're not
and
allowed to.
hopefully they have that previously arranged and have a funeral home
But
chosen.
guess what? You would think so, right? No.
Hopefully.
There are so many families who are clueless
Yes.
in denial.
Yeah.
I mean, when you go to
That's
long-term
a
care,
real
it's
thing.
not a
You
vacation.
don't know.
Like, you pretty much are going to be there until the end. So maybe you want to get thinking about getting your ducks in a row and getting funeral
Maybe they
arrangements.
thought that their mom was going to live 10
It's
more years.
okay, you know. You just get those arrangements.
You
it
don't
doesn't
know.
mean it's going to happen next month. Just get those arrangements.
Okay,
Because
so-
what happens, it is a frenzy for everybody. Well, what funeral home do you want to go with? I mean, the cost of funeral homes vary from this to that. So we're not talking about that, though. That's another topic.
So in the hospital, when somebody passes, yes, we do have a morgue in the hospital, and that body needs to get down to the morgue where it can stay cold. So the funeral home can do what they need to do with the body and the preparations, whatever the family needs. But many times the family want to sit with that body for hours. So you're asking me about
that's a long
some
time.
stories.
That's rare, really.
So
that happened quite a bit.
I can
Hours?
share a story of a particular patient who was not from our country, and he had passed, and he had many family members that wanted to come, and they had very specific cultural things they wanted to do around his body, and we had to move him out of his room into our TV lounge room, where he stayed for many, many hours, and it was definitely not appropriate.
That's-
Very terrible, and
Someone should have explained to them about
anyways, it was
Yeah.
not okay what happened, and
management.
eventually
Step up
he
to
did
the plate with that, or they just let it go.
They probably were home because again, this is an evening and a night shift
Oh,
thing.
yeah. Say
Very
something.
large.
Can I say something?
obese.
Can I say something about me, my unforgettable moment, and you can go back to your.
I'm done. You go.
Okay, I have two. This was not even where I'm working now. This was years ago, but I can remember in the lounge room, all the residents are sitting there watching TV, and I look over at this lady, and she was in her chair, slumped a little bit, but she didn't fall out, and it looked like she was sleeping, but she wasn't sleeping. I knew she had passed away. You could just tell. The color of her skin. All the other residents didn't know. But I remember that, like, she wasn't even chronic or acutely sick. It was just a sudden heart attack. That will happen.
Yeah.
So it was like, okay, Carades, let's transfer her to the wheelchair to her room. Try to make it so you're not alerting all the other residents like she's gone.
And
we're
what happened?
We're moving a dead body. Well, I mean, they ultimately knew we were moving a dead body. So,
Okay.
it's not.
That
So
reminds
that-
me.
but-
Okay.
Okay, go ahead.
That reminds me of a time when I was in residential and a man had passed sitting up in his chair in his room. And by the time we had noticed that he had passed, it wasn't much time had gone by between the last time I had seen him and I went in his room. But what had set in? Oh, you ask? Rigor mortis.
Oh, yeah.
What's
Rigor mortis?
Stiffening up. So basically, his body solidified in the position he was sitting in his chair. So his knees were bent.
Yes.
His whole body was in the slouched knee bent. So we had to pick his body up and get it on the bed because the funeral home was now on the way to collect him and take him off to the funeral home. And we couldn't straighten his legs. Oh, it was bad. But they had to just deal with that because that's what they do.
That's what they do. I mean, it's not funny, but that's true.
That's one of my unforgettable moments.
I had another experience, which is really gross, and I'm sorry to even say this, but this was a facility that
Nursing is got some gross
you know,
moments. You
we-
don't have to apologize for that. Boy,
Oh.
we knew what we were getting into.
don't listen. I'm sorry if this is gonna upset you, but this lady had explosive diarrhea. The Carries were all busy. I'm not gonna leave her alone. I mean, yeah, the Carries do a lot of that cleaning and long-term care. Where
Oh.
in the hospital setting,
We do it all.
you do.
We
it all.
do it all, baby.
So but that being said, this facility, the Carries were busy, and I wasn't gonna leave this poor lady like that. So I went to find some gloves, and the facility did not order enough gloves. There were no gloves.
What?
No gloves!
What did you do then, Julie?
Karen, what did I do? I grabbed garbage bags! And I put 2 garbage bags on my hand, double them up. I think I taped them around. Or no,
Okay.
I didn't have time to tape them around. They were long enough.
time to tape. They're long enough.
Okay? I had to have some sort of barrier to
Yeah.
clean this up. Oh, I was
This
just
is
outraged. I called the college. That was just nonsense. I
Okay.
don't work there anymore.
Oh, that's at a different
Oh
facility.
yeah, this was years ago.
Wow, now you work somewhere where they actually provide gloves for you.
Yeah, but you know, with long-term care, I also want to say there's always a supply issue, like especially with special dressings
It
and
is.
lotions. I
Yep.
mean, there are pretty good at it, but there are times where you're frustrated. You're dealing with a special wound, and we know we need this dressing, and you're
Okay, can I
Hospital
also talk about
always
the
has
hospital?
the supplies.
No, okay, actually.
Really?
No. The hospital, okay, at our hospital, every floor has its own budget. And like the
Oh.
medical floor has a medical budget and they have a certain amount of money that they spend on their supplies. And when we run out, which we do run out of things very often, for example, Foley catheters, okay? So if we need another Foley catheter and we don't have it, we have to go walking around the hospital to other units and borrow from them, take from their supply.
And how do
They
they
don't
like
like that. They don't like it, but that came from our budget. Well, excuse me, you go jot it down, you just go talk to the managerial. I got a job to do. I don't really care. My patient needs this Foley. I'm taking it.
Yeah, like don't worry, nurse.
It's not coming out of your
pocket.
paycheck.
Oh my gosh.
So some people can get really protective about their supply.
That's really dumb.
So it's really frustrating because again, this is happening evening
Which
and
does
night
happen in
shift
long-term
when
care
the
too
managers
sometimes,
aren't
you know,
there,
just-
and you're dealing with nurses who are very protective about their supplies. Yeah. So
That's frustrating.
So that's very frustrating because you are literally walking around the whole hospital looking for supplies and wasting so much precious time. No, that did happen recently, so that's fresh on my
All
mind.
right, so it's fresh on your mind. Get it out. Thanks for watching our channel, Nurse Twin Talk. If you liked it, please be sure to give it a thumbs up. Comment below what you want us to talk about next time. If
This
you have
is
any
our
questions
first
or comments,
video.
this is our first video.
Please be kind.
Thank you.
That's all I have to say.
Please be kind.
Thank you.
Don't bash us too bad.
You know, we
And
love
then I
our
come back.
jobs. We love what we do.
Yeah, I mean it's
It's a very rewarding job.
it's very stressful, completely stressful,
Yeah.
emotionally,
Yeah.
physically. Just you need to go home and you need a vent. Like
Yeah.
each day is never like the day before, never. And that's very exciting and very interesting. And it is rewarding to help people to go to work and
Yep.
you've made a difference in their lives.
Okay, we're really hot now. We need to.
I know. I'm
Open the
sorry.
window.
Okay, so goodbye. What's
Bye.
our goodbye? But no, that's weak.
Oh, sorry. That's our goodbye.
That's just okay. Bye.
I'm not kissing.
Did you?
her.
Don't kiss.
Cut that kiss out.